Good afternoon.
Good afternoon, sir.
Today I should talk about something else. Especially, I also thought that it is important that many times you are asked about the patient's history, especially the past history of anti-TB drug, because your generation is new, so you should also know what has been the treatment in the past also. Because patient may come to you who might have been treated 20, 30 years back and maybe presenting with you, then you are asked with question what treatment he might have been prescribed during that time. So with keeping that in mind, actually this lecture I delivered very recently in Guwahati, and where I was asked to deliver a guest lecture on tuberculosis, past, present, and future. So I thought it will be important for you and important for your examination to understand how tuberculosis especially was treated in past, what is the present, and what is maybe, if the time will permit, I will go what is going to be future of TB treatment. So that lecture I'm going to, although that lecture I took about 18 minutes time, because time given was 20 minutes, but I finished as per my habit in 18 minutes and conveyed something. The same thing I'm going to convey with you with this little bit of introduction. So I'll skip in the interest of time. I also will skip many slides. Many times you might have heard me, and I usually start my lecture with this Japanese proverb, which says, because I have been in Japan long back, and I learned this from there, that better than 1,000 days of diligent study is one day with a great teacher. I'm not saying that I am a great teacher, but what I said these words to my mentors. These are the first 5 photographs have been my mentors who has mentored me, especially in tuberculosis, I must say. The rest of the people are all India level, and they mentored me maybe in Patel Chest and other place. And these are the institutes, so you already know that where I have worked. And my last institute was Patel Chest, and finally I'm working in ERA. So what I choose a topic for you, tuberculosis, past and present and future. I just told you the genesis. This lecture I presented in Guwahati last month, I think. And so let us see what was tuberculosis in the past. You know, tuberculosis, I used to say that is it was known as white plague in 19th century. And it was it was the captain of all the men of death. Means it was supposed to be a death certificate. Once anybody given a diagnosis of tuberculosis, he was given a death sentence, a death certificate. Why? Because most of the patients, we have hardly any drug. Most of the patients, they used to die. So that was, and you know, these are the type of pictures known in the literature. May it be adult, may it be children, they all suffered from various type of tuberculosis. And tuberculosis has been, as you see in this slide, has been recorded 5000 BC in Egyptian mummies and so on. I'll not bore you with this, but this is a quite old disease. This is all historical pictures we get about tuberculosis. And in 15,000 to 17,000 AD, Probably the cure of tuberculosis was just a touch by king, because it is supposed to be an evil. So there was no hardly bacteria was not invented, drugs were not invented. So that was the genesis behind the tuberculosis. And first time I think the tuberculosis word was introduced in 1774 by BHAI, and who died himself of tuberculosis. You know, those days there was hardly any treatment. And then if you go into the history, the himself devised this gentleman who devised a stethoscope. He himself suffered tuberculosis and died of tuberculosis. And then so that was the story. But this is the man who created history. 24th March 1882 is the landmark day for tuberculosis. He got Nobel Prize, Robert Koch, because he discovered it is not the evil, it is not the God touch and king's touch. It is the bacteria which causes tuberculosis. So that's why every 24th March, the World TB Day is celebrated in his memory. Because first time he told that, yes, bacteria was. So when it was discovered that it is a bacterial disease, and there was no drug at that time, so people started searching for the drug. So when drugs were not available, how tuberculosis was treated? That was known as a sanatorium era. You might have heard, you might have seen some of the sanatorium. I have seen many, at least in the state of Uttar Pradesh where we are living. There were two famous sanatorium. One is Bhavali Sanatorium near Nainital, and another was Gethia. It was again near Nainital. So why you must have understood what was the concept of sanatorium. Sanatorium concept was, since there was no drug, if somebody was used to diagnose, then he has to go to the sanatorium for 2-3 reasons. One, for isolation, because there was no drug. If some TB patient is living in the family, then he will spread disease to everyone. So for isolation, first purpose of sanatorium was isolation. And then, as I told you, all famous sanatorium in the world are near the hill stations. So hill station means good air, quality of air must be very good. So, and then there in the hospital, you have to be provided a very good food, a good diet. So good air, good diet, bed rest, and the isolation. These are the purpose of the sanatoria. And many of our leaders, I will not name, but many of even Pandit Jawaharlal Nehru's wife died of tuberculosis in one of the sanatorium. So what I'm trying to say, these are the sanatoria era. And you see, 1912, King Edward's Sanatorium was started in Bhavali. I just referred it. It is in Bhavali. I have been to Bhavali at many occasions, and there are many more in India. There was, even in London, Brampton Hospital, there was a sanatorium. Edinburgh, so all Germany, so everywhere. That was a sanatorium era where there was no drug, but bed rest, isolation, good food. Those were the ethos behind the sanatorium. And believe me, that there was a one paper which was published. I could not. I'll not able to share that paper, which published way back in 60s. That what was the fate of tuberculosis if you don't treat? I mean, when there was no drug, how will you treat? So that paper was generated in 1960s, one of the very landmark papers. I still remember somebody asked me the VAIVA in my while I appeared in lecturer's interview that if you don't treat tuberculosis, what will happen? So I was knowing that paper. So, 1/3 of the people used to be cured, right? 1/3, and majority of the people, they used to die. So, that with their immunity, with the natural immunity, 1/3 of patients, they used to be cured, but majority used to die. So that was what happened in sanatorium because of their innate resistance, whatever immunity they have. With that, they have some of the people who lived in sanatorium, they are still alive. And that was the reason. Not that the sanatoria was the treatment. So in sanatoria, what I was trying to you, bed rest, nutritious diet, collapse therapy, these are all practiced in sanatoria. You might have heard artificial pneumothorax. You might have heard the pneumoperitoneum. They were the methods of treatment. Even when I was PG student way back in 76, we used to give pneumoperitoneum. Some of our teachers used to give artificial pneumothorax. So those were the issues were treatment. So, and they were the seat anchor of treatment in those days. But then the good thing that when bacteria was discovered, people started discovering the drugs. So post-chemotherapeutic era came, and when the first time, I think the first drug invented was in tuberculosis was streptomycin. Streptomycin was the first drug. And then PAS was invented in 44 was the streptomycin. Then PAS, PAS, when I was PG student way back in 70s, even PAS was used as a primary line of drug. But now, and they were also used in second line of drug also, but PAS was also used in primary line of drug. And then isoniazid was introduced in 52, then pyrazinamide, ethambutol, and the national TV program, when these drugs were invented, the government started national TV program, you know about it. And in 62, and then good news about around 66 to 67, the rifampicin was. So after a long gap, rifampicin was introduced. And when rifampicin was introduced in 1966, some Italian scientist has discovered it, and then the short-term chemotherapy, what we have today, was planned and studies. 66 drug was invented. All the studies of short-term regimen were started in 70s. And when 5-year follow-up of those regimens came, that yes, short-term regimen is as good as a long-term regimen. I will say, what do you mean by long-term regimen? But then the short-term regimen. So what I'm trying to emphasize upon you is still there are many patients whom we are treating with long-term regimen because they were not tolerating these newer drugs. So even those regimens you have to know, and even that the sentence you must see that when shorter regimen was introduced, when they were found as good as longer regimen. Longer regimen is for 2 years, and shorter regimen were 6 to 9 months. That was so longer regimen are not bad because at that time whatever drugs are available they were. And then you must be knowing that another person who got Nobel Prize was who discovered the streptomycin. For this discovery, he got Nobel Prize. And then when drugs started coming, there are 2 research centers in India, which has led to the whole world. And one center this is the Chemotherapy Center Madras. At that time, this was known as Chemotherapy Center Madras. Now it was renamed recently It is the Institute of TB Research. So that was, and but a large number of scientists, even Western scientists, they worked in this center. And one of the landmark study I still remember was done in 59. That what is the role of hospitalization? And in that study, what they did, they treated some of the patients because there were hospital beds. Some of the patients they hospitalized, and other half they gave the treatment at home. At home means it was known as domiciliary treatment. And when 1 year treatment was prescribed to them, and probably treatment prescribed was INH, streptomycin, INH, and PAS at that time. And what they have found, because this is a landmark study which has paved the way for domiciliary treatment. Today, what we are seeing that even TB can be treated at home, except in emergency. So they said that despite bed rest, good food, nursing, good accommodation for hospitalized patients, outcome of disease with chemotherapy was no way superior to that obtained in patient treated at home. That is the point you have to know. So when they studied this, and this was the India who gave this study to whole of the world, and they found that there is no role of hospitalization. Both patients fared well. There's another fear was when we keep these patients at home, there might be spread of disease. But they also saw that no difference in the incidence of contacts of patient treatment through general health care system, what we call it. So I believe that this was one of the landmark studies done in India, not done only for India. It is done for all global. That had changed the practice of TB. And so WHO itself has issued a sermon that for factors which influence the response to treatment was this. They himself said that probably unimportant rest, accommodation, diet, nursing, climate, sanatorium, psycho. They could be important in some of the patients. You know the latest. Some of you must have read the ration trial where they have given the additional food that has shown some benefit, especially in those who have malnutrition. So they said it is unimportant in majority of the patients. What is severity of disease even was, we have seen, I have treated bilateral extensive disease. If you treat them well, they have become all right. And what is important was adequate chemotherapy and its regular. That's why I emphasize in most of my lecture. So, and that you see the history of the 1960, there was another institute, what was known as National TB Institute at Bangalore. They also gave a lot of studies to the whole world about tuberculosis management. And this was started way back in 1960 by then Prime Minister of the country. So, and then, in 62, the NTCP, National TB Control Program, was formulated because drugs were now available. Intermittent therapy is not new. It was started in way back in 64. First intermittent therapy came. And then rifampicin was invented. In 1972, short course chemotherapy trials started. And then around 80s, it was introduced in India. And human program was changed to RNTCP, and now it is NTEP. That is how, and as from DOTS to DOTS plus, for you, it might be a history. DOTS was the RNTCP, means this program. And DOTS plus was for drug-resistant tuberculosis. Now it is known as PMDT, Programmatic Management of Drug-Resistant Tuberculosis. The rule was in the country, I know that I have been seen all those era, when you know the 1992, the review, the NTP were reviewed, started from 62 and they were reviewed in after 30 years, they found that hardly it has not controlled tuberculosis. It has not done any good job. So, and only thing was what they are blamed was not the drugs, not the regimen, but blame was basically on the implementation. Sometimes drugs were not there, sometimes X-ray plates were not there. They are still happening, but a rare phenomenon. So then DOTS was started, and rule was that DOTS plus or drug-resistant TB management will only be started when whole of the country will be covered by the DOTS or RNTCP. So I still remember in 2006, whole country was covered by DOTS, and then DOTS plus started. Later on, it was renamed as PMDT, and you know the program name was even changed in 2019 towards the national TB. Means we are heading towards elimination. And you know, this was the basic ethos of NTCP, National TB Control Program. Districts, that still persists. Districts were, and then there were peripheral centers. And you see what was the regimen, if you see that. So it was, these regimens started from 1962 to up, we can say up to 85, 86. And during this regimen, we have regimen like R1 and R2. And then we have another two regimen, RA and RB. So what was R1 was new cases of tuberculosis, and with the starting with the three drug. New means who are sputum positive cases. They started with three drug. That was INH, thiazone, and streptomycin. Streptomycin could have been daily, could have been alternate day, all the things. And then this is for 2 months, and then 10 months of INH and thiazone. Thiazone could have been replaced with ethambutol. Thiazone could have been replaced with PAS. This is a PAS. P stands for PAS. So as I said in the initial regimen, in NTCP, the PAS was also used, ethambutol was also used, and thiazone was the most common. So that was the drug for sputum positive pulmonary. Idea has remained the same. When bacterial load is there high, then you start three drug at that time. And then R2 was same in sputum negative, means less severe cases. There we can start with two drugs, INS thiazone, INS ethambutol, INS PAS. You can give for 12 months, minimum of 12 months. And even one regimen intermittent at that time, I know when I was PG student, I have injected many people twice injection a week and 650 milligram dose of isoniazid. Because for intermittent therapy, dose of isoniazid was 15 milligram per kg body. So that was the regimen. And I know that we have treated we have seen being treated many patients who completed the therapy. So what I'm trying to show, regimen, whatever regimen at any time, they were not culprit. Culprit was the implementation. And then when these drugs, rifampicin, one pyrazinamide was introduced, then in a national TB program, it was introduced around 80s. And there you know the regimen was either ethambutol, INH, rifampicin, pyrazinamide, 4 drug which we are still using for 2 months. And then in continuation phase, somebody is not 6 months of INH and thiazone. That was a one very popular regimen in those days. Initially you give rifampicin, ethambutol and pyrazinamide, and And then subsequently, you may continue with INH and thiazone, INH ethambutal, are those patients who are not able to tolerate these drugs. But that was a regimen there at that time. And then there was intermittent regimen was also comprising of these drugs were also there. So they were the very common drug regimen used in NTP, National TB Control Program, NTCP, what we can say. And these drugs were used for about 30 years in the country. And when they have used for 30 years, and that was referring to you that when the NTP started in 62. So after 30 years in 1992, it was this very famous slide. It was evaluated by Government of India, WHO, and Swedish International Development Agency in 1992, and what they could find. Like we have joint monitoring mission of RNTCB, we have there the evaluation of NTP. And they say that inadequate budget, outlay, shortage of drugs, overemphasis on X-ray instead of sputum, poor quality of microscopy, emphasis on detection of new cases instead of cure, poor organizational setup. And so they found that the completion rate was less than 30%. So that was the idea, that how NTP failed because of these reasons that people had not. But I can vouch you that we have treated lakhs and lakhs of patients with these older regimens. Sometimes we are still treating because they are not tolerating newer drugs. And they are very effective regimen, I must say. I have treated lakhs and lakhs of patients. Only thing that they should complete the therapy. They should complete the duration. That matters in tuberculosis. What WHO said way back in 74. So that was evaluation was done. And then tuberculosis, WHO has declared emergency on a particular disease that was tuberculosis. What happens that before I go to the treatment further, I would like to talk something about the diagnosis of TB. And this slide is very popular that certain change in nomenclature has happened. That there is some. Initially, we used to call it as TB suspect, and then the social organization objective. Suspect means something very suspect. So this word was changed as presumptive TB. And then case definition also there was changed. I hope I have told you many times that there are only two types of definition: microbiologically confirmed and clinically. And when I say microbiologically confirmed, it is confirmed either by phenotypic, that is by AFB, by culture, or by genotypic, by gene expert, LP, etc. And the rest of the diagnosis is clinically. And pulmonary except pulmonary remain the same, and this one word had changed in recurrent TB. Initially, it was known as relapse. Relapse means patient who has been treated adequately and gets the disease again. That was the definition of relapse. And that relapse has been replaced with the word recurrent. Otherwise, rest of the thing remained the same. So in TB diagnostics, we have, for your information, we have moved from initially people used to diagnose just with symptom, then X-ray came, then bacteriology came, culture liquid, then DST, then molecular diagnostic, and now it is gene sequencing. So that is how the diagnostic scene had changed in India. And there's a lot of tests available today, starting from radiology to microbiology to molecular diagnostics. I'll not go in details. And the tools for diagnosis have been multiple. And these are the diagnostic workup and TP guidelines for diagnosis. And even newer things are being introduced in diagnosis, like artificial intelligence